A 56-year-old woman presented to the emergency department with sudden loss of vision in her right eye, intense eye pain, headache, and vomiting. There are no history of any eye problems except for glasses for hypermetropia. The visual acuity was counting fingers on the right eye and 6/6 on the left eye. The right eye showed circumcorneal injection, diffuse corneal haze, shallow anterior chamber, and mid-dilated fixate pupil. A 67-year-old farmer presented to the eye unit of a teaching hospital with a history of gradual painless vision loss, and he was searching for his glasses change. He has a history of headache, intermittent pain, as well as redness. He is a cardiac patient and hypertensive 20 years ago. His presenting aided visual acuity was 6/6 in the right eye and 6/24 in the left eye. Both corneas were clear, and the pupils had a slow reaction to light. The right eye had a nuclear sclerotic cataract, which precluded a good view of the optic nerve head, and a vertical cup to disc ratio of about 0.7. Barely visible through the dilated pupil was the binocular indirect ophthalmoscope. The left optic disc ratio was 0.5 for the left eye, and the intraocular pressure was 32 mm mercury for the right eye and 27 mm mercury for the left eye by applanation tonometry. Gonioscopy showed narrow angles on both eyes, and slight lamp examination shows atrophic iris patches. Alright, so now that you've finished the two cases are joined together, and the diagnosis most likely for this patient is, for the first case, is known as acute narrow angle glaucoma. Here we're going to talk about glaucoma in general so we can get the idea. This case for the first one is acute narrow angle glaucoma. If you look at the case afterwards, it's talking about narrow angle glaucoma but a chronic. So in general, for the purpose of this video, we're going to consider the diagnosis as narrow angle glaucoma. And what is the difference? To revise back to glaucoma, what is meant by glaucoma? It means this is an eye condition which could be an emergency or not, in which you have high intraocular pressure within the eye. The pressure within the eye increases, and typically this is a problem because whichever may be the cause of the increase in intraocular pressure, it will compress the optic nerve inside, especially the optic disc, and compression of the optic nerve, which is basically known as glaucomatous, optic nerve neuropathy or optic neuropathy, it will eventually lead to vision loss, and this can be permanent. It can be gradual, the process, or it could be sudden. If it's sudden, that's very bad. That means emergency, ala طول. So let's talk about glaucoma for a minute, and let's look at the first case. The first case you saw, why is it considered as acute narrow angle glaucoma? Well, typically a patient with acute glaucoma, if he comes to you, it's a very, very emergency situation, okay? This is an emergency, and typically you have to send him to the ophthalmologist and to the ER immediately. Call the ophthalmologist in the hospital. Because you see what happens, if we go back to the pathophysiology first of glaucoma, let's look at this picture right here. This picture right here is a messed up drawing showing you the back of the eye. So this right here is the lens. This is the suspensory ligament attaching it to the ciliary body. The ciliary body contains epithelium that secretes aqueous humor, water inside your eye. And this water, once secreted, it will go through a circulation. It will come out through this direction. It will come out and it will be reabsorbed back to the ciliary body. So there are excretion pathway that basically the ciliary body, part of its epithelium will produce aqueous humor, and then it will go throughout this way back to the ciliary body or back to its epithelium to be reabsorbed back. But the problem with glaucoma is there is inadequate drainage. There is accumulation of the aqueous humor in the eye. And if there's accumulation in the aqueous humor in the eye, it will lead to increased intraocular pressure. If you have increased intraocular pressure, there will be compression of the optic nerve or the head of the optic disc. And you'll see in fundoscope, if you're able to, not in an acute case, but in chronic cases, you'll see in the fundoscope a picture that basically looks like this. You'll basically look at the optic disc. This is the optic disc, and you'll see the cup of the optic disc, it becomes bigger, and basically the optic cup becomes thinner. So this is the optic cup right here. All right, let's say this is the optic cup right here, this drawing right here. and it becomes a lot bigger. And there's something to basically give this a term. They call this disc to cup ratio. A normal ratio between 0.1 to 0.2. If you have an optic cup to disc ratio of, let's say, 0.7, this is very high. This means that there is optic head nerve changes. There's changes of the optic nerve along with high intraocular pressure that leads to the diagnosis of glaucoma. Also with this is defects in the vision. Not just vision, visual acuity, also visual field. You'll have visual field defects where the patient is not able to see as clearly. He'll see gaps in his vision as well. So you have visual acuity and visual field defect. And this triad of glaucomatous optic disc changes with visual field defect, with increase in intraocular pressure, this is basically a triad that can confirm from you glaucoma. And from this point on, you can do ophthalmic examination, full eye examination, and you can use an instrument like gonioscopy. This is an instrument that will measure the angle of the anterior chamber. Remember this angle right here? This basically this pathway to secrete aqueous humor. We're trying to see the angle of the aqueous humor. Is it narrow or is it wide? Because if it's narrow, then this could be one of the reasons why the aqueous humor is not able to be drained. Okay, so this is one thing to keep in mind, because if we discover it's narrow, we consider this narrow angle glaucoma, and from that point on with the symptoms, we'll know this is acute or this is chronic. If it's open angle glaucoma, and these tend to be chronic. The acute cases, the emergency, like in this case, the first case, it is acute narrow angle glaucoma or acute angle closure glaucoma. So now we look at the pathophysiology of glaucoma. What are the symptoms that the patient will have? Well, in an acute case with sudden rise of the intraocular pressure, and there's many causes. One of the causes in acute attack is mydriasis, and this makes sense. Whenever this lens, when it becomes bigger, it can basically occupy this part of the anterior chamber. It can basically mediate mydriasis, meaning dilated pupil, or when the pupil becomes larger, let's say the pupil becomes larger, not the lens. Basically, this will constrict or make the place where the aqueous humor is being drained even narrower. So if it's becoming even narrower, then there is a likely chance of sudden rise of intraocular pressure, acute attack. And there are cases, let's say there are cases of dilated pupil normally when you're stressed out. And females tend to be more stressed out than females, so they tend to be at risk. Also, if you have a case of any case that you might need your sympathetic nervous system activated. For example, in a case of stress, or let's say in a dark room. If I'm in a dark room, my pupils will dilate. Or if I use, let's say I have for genetic purposes, I have a narrow angle, so I'm predisposed to an acute attack, and let's say I use an atropine eye drop, and if you remember atropine causes pupillary dilation. This can basically cause the issue of the aqueous humor not being drained properly because there's such a narrow space or narrow angle, and this can lead to an acute attack. So what are the symptoms of acute glaucoma or acute narrow angle glaucoma? First is acute painful vision loss. You lose your vision and you'll have very severe eye pain, Along with that, your eyes will be red. One of the differential diagnoses of red eyes is acute angle closure glaucoma. Your eyes will be very red, the sclera especially. You'll have photophobia, of course. You'll also have what is known as a corneal haze. Basically, so much aqueous humor is not being drained to the point that the cornea will be affected as well. There will be corneal edema, and when you look at the cornea through a slit lamp, you'll see that the cornea is affected. There's a haze. There's something that's making the cornea not as clear. So there's going to be a corneal haze as well, which can give you a sign of acute glaucoma. Along with that, you'll have tearing, a lot of discharge coming from the eye, and you'll have increased intraocular pressure and narrow angle when you're looking at examination. So if you take all of these symptoms, these are symptoms you'll see in acute glaucoma, especially in an adult. So differential diagnosis, as we said, based on the patient's symptoms. Like we said in another future video, this patient might have endophthalmitis, this patient might have uveitis, this patient might have keratitis. These are differential diagnoses. But we're focused on glaucoma, most likely acute narrow angle glaucoma. So this is for differential diagnosis and the diagnosis. Investigation we mentioned before. And since I told you the triad of glaucoma, you must do ophthalmic examination. The problem is in an acute attack is difficult. You can't do all of the examination. The thing you can do is take history, take ophthalmic examination slit lamp, do gonioscopy to measure the angle, and you can have another device called tonometry to measure the intraocular pressure. You can measure it by a device known as Goldman implementation tonometry. It's basically like a blue laser, and they will see what is the amount of intraocular pressure. So you can do some of these quickly to determine this is acute glaucoma, because this is a very severe case. If it's a chronic case, no, you can do full examination and investigate the triad. You'll investigate the fundus for glaucomatous changes in the optic disc, visual field, and so forth, okay? And the treatment, let's say we have a patient with acute glaucoma. What will be the treatment? Well, the treatment is as followed. First, the patient has to be admitted to the ER. He has to call the ophthalmologist, and the ophthalmologist, what will he do? He'll come here and he'll give the patient for the affected eye pilocarpine. Pilocarpine is an acetylcholinesterase inhibitor. Its purpose is we will constrict the pupil, okay? They will constrict the pupil. They give it as an eye drop every 5 minutes till that pupil constrict. And then if we need to, or if they need to, they'll add another drug that can cause mydriasis, such as timolol, a non-selective beta blocker, or let's say one of the alpha-2 agonists like bromidine. So they can add to that as well. And let's say the intraocular pressure is very high. And mind you, the normal intraocular pressure is basically less than 21. Less than 21 millimeter mercury. So let's say we have an intraocular pressure of 50. Then we can add another drug, like a carbonic anhydrase inhibitor, acetazolamide. So until the intraocular pressure decreases, because that's what we want. The goal of therapy is we want to prevent the progression of further vision loss and eventually permanent vision loss. Because the problem with glaucoma, if there is vision deterioration, is permanent. It is permanent. We're not trying to stop it, or we're not trying to reverse the condition. We're trying to prevent further deterioration. So that's the idea. So we're going to lower the intraocular pressure with all these medications I mentioned above. And once we stabilize the eye, once we notice that the cornea is starting to become clear, the intraocular pressure is starting to decrease, next what we have to do is surgery on the eye itself. They might do trabeculectomy, which basically means we do an opening in the trabecular mesh network of the ciliary body, basically the site of aqueous humor drainage. Regardless, whatever surgery they'll do for the affected eye, they'll do it. And they'll not stop there. They'll also have to do surgery for the other eye. The other eye that's normal. What surgery they'll do? They'll do a surgery which is basically known as YAG laser peripheral iridotomy. So basically here, and I messed up the spelling, but we have YAG laser peripheral iridotomy, a surgery that will be done for the other eye that is normal in acute glaucoma. They'll do this as prophylactic surgery so that the other eye is not affected and the intraocular pressure will not decrease. This surgery is basically there to, let's create a gap. Let's create an opening within the iris so that the aqueous humor can be drained adequately in the other eye. So that's going to be very important. If you remember from previous videos, the YAG laser, this is the laser used for in acute glaucoma. And it's also the laser that's also used in cases of post-cataract surgery complications such as PCO. Patients that develop cataract after cataract surgery for the remaining of their original lens, they'll use the same laser to penetrate through this lens to fix their issue. So this is something to keep in mind. So the treatment for acute glaucoma is as follows. There's medication and then surgery. Admission, then the medications that's followed, pilocarpine, add with timolol if you need to, alpha-2 agonists if you need to, carbonic anhydrase inhibitors if you need to, as eye drops, give it every 5 minutes till the pupil constrict and the eye is stabilized. All this, by the way, is achieved within 1 day, 24 to 48 hours. And then once it's stabilized, do surgery for the affected eye. And then once you're done, you'll do surgery for the other normal eye, known as YAG laser prophylactic peripheral iridotomy. Okay? This is the management for glaucoma in an acute case. This is one type of acute angle closure glaucoma. I already mentioned to you that one of the risk factors is mydriasis, but there are also other risk factors for acute narrow angle glaucoma. For example, patients that have a refractory error. Let's say patients with hypermetropia. Hypermetropia, if you don't know, it is a condition basically like presbyopia, but let's say can occur in younger age, in which people that see near objects, they see it as a blurry. They see blurry nearby objects, but their distant vision is fine. So in the cases of people with hypermetropia, their problem is that their eyeball, let's say this is the eyeball right here, the axial diameter of their eyeball is very small. So instead of looking like this, it becomes basically like this. So if you can imagine it, this can basically give less space, less room for the aqueous humor to be drained. So people with hypermetropia, especially high hypermetropia, they might be predisposed to narrow angle glaucoma. So that's another one to keep in mind. Also patients with diabetes, also patients from the 50, 60 age group. That's why most people that have acute angle glaucoma, they tend to be elderly in the 50s and their 60s. Okay, so these are also risk factors to keep in mind in acute glaucoma. Basically, we finished, but now we will compare it to other types of glaucoma. We have divided the glaucoma into basically adults and children. Regarding the adults, we already talked about primary narrow angle glaucoma. Now we're going to compare primary narrow angle glaucoma, which can be acute or chronic, compare it to other types of glaucoma. And here, actually, the most common type of glaucoma you might see is the primary open angle glaucoma. From the name, primary open angle, you have glaucoma, but the angle of the anterior chamber of the eye, it is open. It is not narrow. Yes, you can have glaucoma despite an open anterior chamber. Reasons are unknown, but the risk factors for primary open angle is quite interesting. Here, the risk factor regarding refractory error is not hypermetropia. It's the opposite. It is myopia. So patients like me who have myopia, I'm not saying it's guaranteed, but it's associated. Myopia patients, they tend to have the opposite of hypermetropia. Their axial diameter is high, and that's why people like me with myopia typically have to wear concave lenses so that the light basically goes all the way to the retina. And people like me, we have big eyes in their diameter, so basically the eye does not go all the way through. The light will be in front of the retina. So this is the retina right here, and we're looking at a cross-sectional view, and this is the light. So the image will be in front of the retina. And people with myopia, they tend to be at risk of open angle because there's a bigger space, so there's a bigger room, you can imagine it, for aqueous humor to be produced and fill up the room. So you can think of it as that as an idea. So that's a risk factor for it. Besides that, the same diabetes mellitus as a risk factor, age, and so forth, as a risk factor for open angle glaucoma. And typically open angle is not serious. It will not give you these symptoms. In fact, primary open angle glaucoma, by the color blue, will give you chronic painless visual. Typically, the patient will either be asymptomatic or he'll be complaining of slowly deterioration of vision. When you do examination, you'll see the three triad: high IOP, glaucomatous optic disc changes, visual field defect. But the symptoms might be asymptomatic or just slowly deterioration of vision painlessly. That's pretty much it. And the treatment for it, typically you don't have to do through the treatment you don't have to do the treatment for open angle like you did for narrow angle, but you have to give them medication, anti-glaucoma medications, and you at some point have to do surgery, at least the prophylactic surgery that we mentioned for the eye laser for the other eye. Okay? Typically you start with medication to control the intraocular pressure. If it failed, try the laser surgery. If that failed, you have to do surgery. This is for primary open angle glaucoma. Besides the primary open angle glaucoma, there's another type, and that is ocular hypertension of glaucoma suspects. Ocular hypertension is not glaucoma. It is basically a condition that warns you that a patient might have glaucoma. So in ocular hypertension, you'll have a case of a patient who basically is asymptomatic and he has no signs. He has no visual field defect. He has no glaucomatous optic disc changes. However, his intraocular pressure is high. That's why we call it ocular hypertension. So they have a high intraocular pressure, but everything else was normal. So they considered ocular hypertension, basically, there is a risk factor. You might develop a glaucoma, like an open angle, narrow angle, whatever, okay? Or you might develop a glaucoma known as normal tension glaucoma. Now the thing is, we need to know the difference between normal tension glaucoma and ocular hypertension. I mentioned before, ocular hypertension, you have high intraocular pressure, but everything is normal, including the signs. However, in normal tension glaucoma, it's the opposite. In normal tension, your intraocular pressure is normal, but you have the symptoms and the signs of glaucoma. So in normal tension glaucoma, patient may be asymptomatic, or the patient may have basically chronic painless visual loss, okay? When you do the fundus examination and all the other examinations, you'll see he has the triad of glaucoma. The difference, his intraocular pressure is normal. Do we consider this as glaucoma? Yes, but we call this normal tension glaucoma. Okay? These are the types and the differences we need to combine, and these are pretty much it. Again, the treatment for normal tension glaucoma and ocular hypertension, again, anti-glaucoma medications. Typically, you try to lower the intraocular pressure, you keep it stabilized, you prevent it from going up. So that's the general idea behind it. Besides those types, now let's look at the children. Now we have juvenile, infantile, and congenital. I want to tell you one thing. Congenital, juvenile, infantile, they're basically the same thing. We just divide them in children according to the severity of the symptom. So take, for example, juvenile. Juvenile, this is glaucoma. It's similar to primary open-angle glaucoma, but in teenagers or young adults like me. I'm 22 years old. I'm 22 years old, and if I have the symptoms of primary open-angle glaucoma, they might consider this as juvenile glaucoma. It's not really that serious. Infantile and congenital are the same thing. The only difference is the onset. Congenital glaucoma is considered congenital glaucoma when you have a neonate. When you have a baby that's born up to 2 years, you consider it as congenital glaucoma. Infantile basically at a later age onset, let's say 6 years or 7 years. And the symptoms of infantile you'll see is much less severe than compared to congenital glaucoma. Because we will see in congenital glaucoma, there is anterior chamber dysgenesis. No narrow angle, no open angle. There's nothing to do with the angles. There's something to do that there is literally no ability, no area to excrete the aqueous humor. There's an anterior chamber dysgenesis due to a problem in development, okay? So let's look at congenital glaucoma and why it's much more severe than infantile, in which they basically have the same problem, but their anterior chamber is much more developed, less dysgenesis than compared to congenital. So let's focus on congenital glaucoma, because that's the most important thing, and what are the things we need to keep in mind. So in congenital glaucoma in a baby, we have a baby that comes to you in pediatric ophthalmology department, and this baby is an emergency case. This baby, let's say this is its eyes, you'll see its eyes is red. He has red eyes. Not only that, you'll see his cornea is large, very large cornea. We call this megalocornea, okay? And not only that, the eyeball will be known as bulb ophthalmos, known as enlarged globe. There's an enlarged eye. So you look at the diameter of the globe and you look at the cornea, it's big. You'll see, what is this? Why is this in congenital glaucoma? You'll not see these signs in other types of glaucoma, only in congenital. Why? Because remember, the eye is still developing in the baby. Up to 2 to 3 years, it will finish developing. But if I have accumulation of fluid or humor in the developing eye of the baby with increased intraocular pressure, it will affect the surrounding structures. So you can think of it as a balloon. It will get bigger and bigger and change its size. And of course, in glaucoma, it will be stony hard, and you'll have an enlarged corneal diameter, megalocornea, and the eye in general will be big. We call it bulb ophthalmos. So the baby will come with this sign, and he'll also come with, like we said, redness. He'll come with lacrimation, as if the eye is about to explode. There's a lot of watering, there's tears coming out of it. So there's watering, and there's redness, and there is pain, irritability, and there is definitely photophobia, and there will be acute painful visual loss, the whole 9 yards, okay? So it's as if we took the symptoms of acute narrow angle glaucoma, we put it in congenital, but there are specific signs, such as the fact there's megalocornea and there's bulb ophthalmos, and at that point, if you see it in a baby, you have to do surgery. Here, surgery, immediate surgery. You have to do trabeculoplasty. You have to make sure, because here's the thing, what's the midpoint of medication? There is no aqueous humor to be drained of. That's the problem with congenital glaucoma, aqueous humor dysgenesis. So we will do surgery to open up holes in the trabecular network, or epithelium to the ciliary body, to allow for this aqueous humor to be drained. So do trabeculoplasty, okay? It's immediate. Otherwise, this congenital glaucoma might lead to permanent loss of vision and amblyopia. And if it's not going to lead to permanent loss of vision, it will eventually with amblyopia. If you don't remember amblyopia, you can look at previous videos. It is loss of vision because one eye is being neglected by the brain because it's giving a poorer signal compared to the normal eye, okay? We finished glaucoma. That's pretty much it. And we mentioned this point right here, ocular hypertension symptom free, and the colors give you the key differences. If you notice, intraocular pressure is high in all these types, all of them actually, except for the normal tension glaucoma, from its name, normal tension. We finished glaucoma, and I hope you enjoy.